March 21, 1918. The Somme Valley, France. Dawn breaks over the British lines with an eerie fog that seems to swallow sound itself. Within hours, over 1 million German shells will rain down in Operation Michael, the Kaiser's desperate gamble to win the war before American forces arrive in strength. But the British Army faces an enemy even more terrifying than the German spring offensive. In the field hospitals stretching behind the front lines, doctors and nurses are collapsing at their stations, not from exhaustion, not from wounds, from an invisible killer that respects no rank, no uniform, no national boundary. Spanish flu has arrived on the Western Front, and it's killing medical staff faster than German artillery can kill soldiers. Within days, entire hospital units will be reduced to skeleton crews. Thousands of wounded men lie on stretchers with no one to treat them. The British Army Medical Corps faces a crisis that threatens to do what 4 years of German offensives could not: collapse the British war effort from within. What happens next is a story of desperate innovation, unlikely heroes, and medical breakthroughs forged in the crucible of dual catastrophe. This is the untold story of how Britain's improvised medical response in the spring of 1918 saved not just lives, but the entire war effort itself. The numbers tell a grim story. By mid-March 1918, casualty clearing stations behind the British lines report that 30% of their nursing staff are bedridden with influenza. At number 3 Canadian Stationary Hospital near Dowlands, 22 of 60 nurses fall ill in a single week. 6 will never recover. Major William Grant, the senior medical officer at a casualty clearing station near Amiens, writes in his diary on March 18th, "The wards are full of our own staff. We have more nurses in beds than we have nurses standing. God help us when the German attack comes. Everyone knows it's coming." Grant doesn't know how prophetic his words are. 3 days later, the German offensive explodes across a 50-mile front. Within hours, British casualties begin flooding rearward in numbers not seen since the first day of the Somme. Horse-drawn ambulances, motor vehicles, even commandeered farm carts stream toward the casualty clearing stations. The wounded arrive covered in mud, blood, and the chemical burns of gas attacks. They need immediate surgery, wound cleaning, tetanus shots, blood transfusions. But the medical infrastructure meant to save them is itself in crisis. At Casualty Clearing Station number 47, Lieutenant Colonel Arthur Martinleake, a double Victoria Cross recipient and one of Britain's most decorated medical officers, faces an impossible situation. His station is designed to handle 200 patients. By noon on March 22nd, over 800 wounded men lie in every available space: the surgical tent, the recovery wards, the corridors, even the ground outside. Martinleake has 6 doctors still standing. 3 are showing early flu symptoms. He has 14 nurses. 5 are already bedridden. The mathematics are brutal and simple. Each serious case requires at least 30 minutes of surgical attention. With the current staff, they can handle perhaps 20 operations in a 12-hour shift, but casualties are arriving at a rate of 50 per hour. The equation doesn't balance. Men will die not from their wounds, but from the absence of care. And this scene is repeating at every medical facility behind the British lines. The crisis reaches London within days. At the War Office on Whitehall, Director General of Army Medical Services, Sir Arthur Sloggett receives increasingly desperate telegrams from France. The situation is critical. "We are losing medical personnel faster than we can replace them. Wounded men are dying of treatable injuries due to lack of staff. Request immediate reinforcements. But where can reinforcements come from? The regular nursing reserves are already deployed. The voluntary aid detachments, those brave civilian volunteers who have staffed hospitals throughout the war, are stretched thin. The medical schools are nearly empty, their students already in uniform. Sloggett makes a decision that will be remembered as either brilliant or desperate, depending on who tells the story. Perhaps it's both. He orders his staff to cast the net wider than ever before. Recruit anyone with any medical training whatsoever. Retired nurses who left service years ago. Veterinary surgeons who have spent the war treating horses, not humans. Dental students who have never seen a gunshot wound. Medical students who haven't finished their training. Even pharmacists and midwives. Britain is about to create an improvised medical corps from the most unlikely collection of healers ever assembled. The call goes out across Britain on March 25th. Newspapers carry urgent advertisements. Medical personnel needed immediately for service in France. All qualified individuals encouraged to volunteer. Age limits waived. In Edinburgh, 58-year-old Margaret Fraser reads the notice in the Scotsman. She trained as a nurse in the 1880s, but retired 15 years ago to care for her aging parents, both now deceased. She hasn't treated a patient since Queen Victoria was on the throne. Medical techniques have advanced dramatically. Antiseptic procedures, blood typing, new surgical methods. She's decades out of practice. But Margaret remembers the satisfaction of nursing, the profound purpose of easing suffering, and she thinks of the young men dying in France for want of care. She volunteers that afternoon. In rural Yorkshire, veterinary surgeon James Whitmore receives a telegram directly from the Army Medical Corps. His expertise in emergency surgery and his experience treating traumatic injuries in horses make him valuable. The telegram is blunt. Your skills are needed. Human patients now. Report to Southampton in 3 days. Whitmore has never treated a human being in his professional life. But he understands trauma, blood loss, infection, and the brutal mechanics of how bodies fail and how they can be saved. He packs his surgical kit. In London, 22-year-old dental student Robert Chen faces a difficult choice. He's in his final year at the Royal Dental Hospital, just months from qualification. His parents, Chinese immigrants who run a small shop in Limehouse, have sacrificed everything for his education. But the recruitment officer is clear. We need anyone who can hold a scalpel and follow instructions. You'll save lives. Robert signs the papers. Within a week, this unlikely collection of volunteers arrives in France. They're rushed through the most abbreviated training in British military medical history. A single day of orientation at the base hospital in Etaples. Here's how you identify gas gangrene. Here's the current protocol for gunshot wounds. Here's how to prioritize patients when you have more casualties than you can possibly treat. That last lesson, triage, will become crucial. The word itself comes from the French trier, to sort. But the systematic approach to sorting casualties by survivability is still evolving. The traditional method is simple: treat patients in the order they arrive or by rank. But when you have hundreds of casualties and limited staff, that approach kills people. The most severely wounded consume vast resources and often die anyway. The lightly wounded can wait. The key is identifying the middle group, those who will die without immediate treatment but will survive with it. This is where the improvised medical teams will make their greatest contribution. Margaret Fraser arrives at Casualty Clearing Station number 33 near Albert on April 2nd. The German offensive is in its second week. The station is chaos. Wounded men on stretchers cover every surface. The air reeks of blood, antiseptic, gangrene, and the sweet-sick smell of gas burns. The noise is overwhelming. Groans, screams, the constant rumble of artillery from the front just miles away. A harried nursing sister, herself clearly ill with flu, grabs Margaret's arm. "Can you do wound dressings?" Margaret nods. The sister points to a barn converted into a ward. 50 men in there. Change every dressing. Watch for infection signs. Call for a doctor if you see gas gangrene. Go. Margaret enters the barn and confronts the reality of industrial warfare. Men with limbs missing, faces destroyed by shrapnel, abdomens torn open. Burns that have melted uniforms into flesh. For a moment, she's frozen. This is beyond anything in her experience, beyond anything she imagined. Then training from 30 years ago resurfaces. Focus on the task immediately in front of you. One patient, one wound, one dressing. She moves to the first stretcher. A young private, perhaps 20, with a shrapnel wound in his thigh. The dressing is soaked through with blood and fluid. Margaret kneels beside him. "I'm Nurse Fraser. I'm going to change your dressing. This will hurt, but I'll be as gentle as I can." The private nods weakly. As she works, Margaret realizes something. The fundamentals haven't changed. Cleanliness, gentleness, attention to the patient's pain and fear. Her hands remember the motions, and she has something many of the younger nurses lack: decades of life experience, an unshakable calm that comes with age. The private watches her face as she works. "You've done this before." "Thousands of times," Margaret lies. "You're in good hands." She moves to the next patient, and the next. Hours blur together. James Whitmore, the veterinary surgeon, faces a different challenge. He's assigned to the surgical team at Casualty Clearing Station number 62. The chief surgeon, Captain Edward Thompson, is blunt during their first meeting. "I understand you've never operated on a human." Whitmore nods. "But you've done emergency surgery under field conditions." "Yes, horses mostly. Shrapnel wounds, broken limbs, emergency amputations." Thompson considers this. The anatomy is different, but the principles are similar. Blood vessels need to be tied off. Damaged tissue needs to be removed. Infections need to be prevented. "Can you follow instructions precisely?" "I can." "Then you're a surgeon as of now." "We'll start you on limb wounds. Watch me do 3, then you'll do the 4th with my supervision. By the end of the day, you'll be operating independently. We have no choice." Thompson isn't exaggerating. By afternoon, Whitmore is performing his first solo surgery on a human patient. A corporal with a mangled hand from a grenade explosion. The damage is severe. Bones shattered, tendons severed, tissue pulped. In peacetime, a specialist would spend hours trying to reconstruct the hand. Here, the calculation is different. The hand cannot be saved, but the arm can. Amputation is necessary. Whitmore has performed this procedure on horses dozens of times. He knows the critical steps: control bleeding, cut cleanly through tissue planes, preserve as much healthy tissue as possible, seal blood vessels, leave a stump that can heal and eventually bear a prosthetic. His hands are steady. The surgery takes 20 minutes. The corporal will live, will keep most of his arm, will eventually return to some form of normal life. As Whitmore closes the incision, he feels a strange mixture of horror and satisfaction. This is nothing like veterinary practice. The stakes are immeasurably higher. But the core skill, the ability to make life-or-death decisions under pressure and execute them with precision, transfers perfectly. He moves to the next patient. Robert Chen, the dental student, discovers his unexpected role. He's assigned to the admissions tent, where casualties first arrive from the front. His job is triage. Sort the incoming wounded into three categories: minor injuries who can wait, critical cases who need immediate surgery, and the third category, the one nobody wants to acknowledge: those too severely wounded to save, who should be made comfortable but not consume precious surgical resources. It's a brutal calculus. Robert is 22 years old. He's never made a life-or-death decision. Now he must make dozens per hour. A sergeant major, himself wounded, serves as his guide for the first shift. The sergeant's name is William Price, a career soldier who's been on the Western Front since 1914. Price teaches Robert the grim arithmetic of triage. Look at the chest wounds first. If they're sucking air, that's immediate surgery or they die. Abdominal wounds, same thing. Limb wounds, even severe ones, can usually wait an hour or two. Head wounds, you have to judge. If they're conscious and talking, good chance. If they're unconscious with visible brain injury, probably not savable with our resources. Price sees Robert's face. I know how this sounds, lad, but here's the truth. If you send a dying man to surgery, you're killing two other men who could have been saved in that same time. Your job is to save the most lives possible. That means making choices that will haunt you, but it also means men go home to their families who otherwise wouldn't. Robert nods, not trusting his voice. His first real test comes an hour later. Two casualties arrive simultaneously. A young private with a severe leg wound, bone visible, blood pumping, and a lieutenant with a chest wound, breathing labored, lips turning blue. Both need immediate surgery. There's one surgical table available. Robert must choose. He examines the private first. The leg wound is horrific, but the bleeding is mostly controlled by a tourniquet applied at the front. Painful, urgent, but not immediately fatal. The lieutenant is different. Robert can hear the wet, sucking sound of air entering the chest cavity through the wound. A pneumothorax. Without immediate intervention, the lieutenant will suffocate as his lung collapses. The choice is clear, though no less terrible. Private goes to the waiting area. Lieutenant goes to surgery immediately. Robert makes the call. The private is carried to a ward, morphine administered. The lieutenant is rushed to the operating tent. 20 minutes later, Robert learns the lieutenant survived the surgery. The private is still waiting, in pain but stable. Robert made the right choice. He'll make hundreds more in the coming weeks. This is the reality of the improvised medical corps in April 1918. Retired nurses, veterinary surgeons, and dental students holding together Britain's medical infrastructure through sheer determination and rapid learning. But they're not just maintaining the status quo. They're innovating. The crisis is forcing new approaches that will revolutionize military medicine. The breakthrough comes from an unexpected source. Major William Grant, the medical officer who predicted disaster in his diary, is himself recovering from a mild case of flu. Bedridden but conscious, he has time to observe the chaos of his own casualty clearing station from a patient's perspective. What he sees appalls him. There's no system. Casualties arrive and are treated based on whoever the nearest doctor or nurse encounters first. Severe cases wait while minor injuries are bandaged. The surgical team operates on patients in near-random order. Resources are wasted. Lives are lost unnecessarily. Grant, trained as both a physician and an engineer before the war, sees the problem in mechanical terms. This is a flow problem. Inputs exceeding processing capacity. The solution isn't just more staff, though that helps. The solution is optimization. When Grant returns to duty on April 15th, he implements a radical reorganization. He divides the casualty clearing station into distinct zones. Zone 1, immediate triage. Every incoming casualty is assessed within 5 minutes by an experienced medical officer, tagged with a colored card, red for immediate surgery, yellow for urgent but can wait, green for minor injuries, black for dying, comfort care only. Zone 2, pre-surgical preparation. Red tag patients are immediately moved here. Wounds are cleaned, blood type determined, tetanus administered, patient prepped for surgery. This happens in parallel with ongoing surgeries, creating a pipeline. Zone 3, surgery. Operating tables run continuously. As one patient finishes, the next is already prepared and waiting. No downtime. Zone 4, post-surgical recovery. Intensive monitoring for the first 24 hours. This is where many patients are lost to infection or complications. Grant assigns his most experienced nurses here. Zone 5, recuperation. Patients stable enough to eventually move to base hospitals. Requires less intensive care. This is where he places his less experienced volunteers. The system is revolutionary. It's the assembly line concept applied to medicine. And it works. Within 3 days of implementation, Grant's casualty clearing station increases its patient throughput by 40%. More importantly, mortality rates begin to drop. Patients are getting the right care at the right time. Surgical resources are focused on those who can be saved. The system spreads. Other medical officers visit Grant's station, observe the process, and implement their own versions. By early May, most British casualty clearing stations have adopted some form of systematic triage and zone treatment. The impact on mortality is dramatic. In March, before the system, the mortality rate for seriously wounded soldiers reaching casualty clearing stations hovers around 40%. By late May, it's dropped to 15%. Thousands of men who would have died are surviving. But the improvised medical corps contributes more than just organizational innovation. They pioneer new sanitation protocols that address one of the war's deadliest killers, infection. Gas gangrene caused by bacteria in the mud of France kills more men than German bullets. The traditional approach is aggressive. Cut away all damaged tissue, amputate liberally, hope for the best. But Margaret Fraser, drawing on her decades-old training in the early days of antiseptic medicine, suggests a different approach. She's working in a recovery ward when she notices a pattern. Patients whose wounds are irrigated frequently with saline solution, keeping them constantly clean, develop fewer infections than those whose wounds are simply dressed and left. She mentions this to Captain Thompson, the surgeon who trained James Whitmore. Thompson is skeptical at first. The current protocol, based on wartime experience, emphasizes surgical debridement, cutting away tissue. But he's also desperate. Infection rates remain stubbornly high despite all efforts. He authorizes Fraser to try her approach on a trial basis. One ward, 20 patients with serious wounds at high risk for gas gangrene. Constant irrigation with sterile saline. Dressings changed every 4 hours instead of twice daily. Wounds inspected constantly for early infection signs. The workload is immense. But Fraser organizes her team of volunteer nurses, mostly older women like herself, into a rotation system. The results are undeniable. After 2 weeks, only 2 of the 20 patients develop serious infections. In the control ward, using standard protocols, 9 of 20 develop infections. 4 die. Thompson immediately expands the protocol across the entire casualty clearing station. Other stations hear of the results and adopt similar approaches. By June, the intensive irrigation and monitoring system is standard practice in British military medicine. It will remain so for decades. The improvised medical corps is literally rewriting the textbook. James Whitmore makes his own contribution. His veterinary background gives him a different perspective on wound treatment. In horses, he learned that traumatic wounds heal better when edges are brought together loosely rather than tightly sutured. Tight sutures in contaminated wounds create pockets where bacteria thrive. Loose approximation allows drainage while still promoting healing. He suggests this approach for shrapnel wounds, which are always contaminated with dirt, uniform fabric, and bacteria. Again, it contradicts current practice. But again, the results speak for themselves. Wounds treated with loose sutures and drainage tubes have lower infection rates and faster healing times. The technique spreads throughout the medical corps. Robert Chen, the dental student, makes perhaps the most unexpected contribution. His training in oral surgery gives him expertise in facial anatomy. When casualties with severe facial wounds begin arriving in large numbers, victims of close-range shrapnel and machine gun fire, the medical corps struggles. Facial wounds are complex, involving bone, muscle, nerves, and blood vessels in intricate proximity. Many surgeons, trained in abdominal and limb surgery, are out of their depth. Chen finds himself consulting on facial cases, then assisting in surgeries, then performing them himself under supervision. His steady hands and detailed anatomical knowledge prove invaluable. He develops a technique for reconstructing shattered jaws using wire frameworks, a precursor to modern maxillofacial surgery. Soldiers who would have been left disfigured and unable to eat solid food regain function. By June 1918, the crisis has stabilized. The German spring offensive has been halted. The Spanish flu, while still present, has burned through the medical corps, leaving survivors with immunity. New staff have arrived from Britain. The improvised medical teams have proven their worth beyond any doubt, but the war isn't over. In August, the 100 Days offensive begins. British, French, and American forces launch the coordinated attacks that will finally break the German army. The offensive generates massive casualties on both sides. But now, the British medical infrastructure is ready. The triage systems pioneered in the desperate spring are operating smoothly. The sanitation protocols are saving lives. The surgical techniques refined under fire are being applied efficiently. Margaret Fraser, James Whitmore, Robert Chen, and thousands like them continue their work through the autumn of 1918. They're no longer improvised amateurs. They're experienced medical professionals who have learned their craft in the hardest school imaginable. The statistics tell the story. In the 100 Days offensive, from August to November 1918, British forces suffer over 350,000 casualties. But the survival rate for wounded men reaching medical care is the highest of the entire war. Over 80% of seriously wounded soldiers survive. Compare this to 1916, when the rate was barely 50%. The difference represents tens of thousands of lives saved. Men who return home, who marry, have children, rebuild their lives. The medical innovations pioneered by the improvised corps in spring 1918 don't end with the armistice. The triage systems become standard in military medicine worldwide. The sanitation protocols influence civilian hospital practice. The surgical techniques are refined and improved. Modern emergency medicine, with its emphasis on systematic triage, rapid treatment, and evidence-based protocols, traces its lineage directly to the desperate innovations of 1918. Margaret Fraser returns to Edinburgh in January 1919. She's 59 years old and exhausted beyond measure, but she's also profoundly satisfied. In 9 months, she estimates she personally cared for over 2,000 wounded soldiers. How many survived because of her care? Impossible to know precisely, but the number is not zero. James Whitmore returns to his veterinary practice in Yorkshire, but he maintains correspondence with Captain Thompson and other medical officers. He publishes papers on wound treatment that are read by both veterinary and human surgeons. The cross-pollination of techniques between animal and human medicine accelerates. Robert Chen completes his dental training after the war, but his experience in France changes his career path. He specializes in maxillofacial surgery, treating the thousands of veterans with facial injuries. He becomes one of Britain's leading practitioners in the emerging field of reconstructive surgery. His techniques, developed in the chaos of 1918, help restore faces and lives. The story of Britain's improvised medical corps in 1918 is not widely known. It lacks the dramatic appeal of great battles or heroic charges. There are no Victoria Crosses awarded for changing dressings or organizing triage systems, but the impact is undeniable. In the spring of 1918, when the British Army faced simultaneous catastrophes, military and medical, a collection of unlikely heroes held the line. Retired nurses, veterinary surgeons, dental students, and others stepped forward when needed most. They didn't just maintain the medical system, they revolutionized it. They proved that innovation under desperate pressure can produce breakthroughs that last generations. They demonstrated that heroism takes many forms, and some of the most important battles are fought not with rifles but with scalpels, dressings, and the determination to save one more life. When the German Spring Offensive crashed into British lines in March 1918, the outcome hung in balance. Military historians focus on the tactical decisions, the defensive battles, the eventual counteroffensive. But behind those frontline struggles, another battle raged in the field hospitals and casualty clearing stations. The battle to keep wounded soldiers alive long enough to return to the fight. The battle to maintain troops' strength through medical care rather than reinforcements. The battle to prove that a nation's character is revealed not just in how it fights, but in how it cares for its fighters. Britain's improvised medical corps won that battle, and in doing so, they helped win the war.